Your scholarship focuses on HIV and experiential education. So tell us about your interest in those, how you became interested in those, and what it's led you to do.
So my interest in HIV first began when I was working as a social worker at the National Institutes of Health back in the early 90s with children who were being treated for HIV for clinical trials at NIH. It was the first center in the country that was treating children with HIV. And my scholarship has focused on that and continued and grown as the HIV field has expanded over the years and changed. So that now those children are young adults and we can prevent mother-to-child transmission, and I've continued to stay interested in the world of HIV. In terms of experiential learning, the Department of Human Service Studies is a leader on campus in experiential learning, specifically service learning. And I got interested in service learning through teaching, and also at my children's school they began to do service learning projects with the children, but they weren't really service learning. They were just volunteering, and so I began to get interested in, can we take what we know about learning in the college setting and service learning and reflection and apply it to younger children? So I've worked with 6th graders, kindergartners, 2nd graders, and 3rd graders around issues of reflection and service learning.
That's fantastic.
It's fun.
Yeah, I was going to ask, has it been fun? What's been fun?
It's been so much fun. It's the best part of, well, not the best, but one of the best parts of my job would be the scholarship that I get to do and then the integration with the teaching.
Fantastic. Now, a lot of your most recent research focuses on some shifts in the HIV epidemic in the U.S. Children born with HIV, of course, are surviving much longer than they did years ago because of improved treatments. So how have you seen their needs change?
So one of the really miraculous things about medicine is that we now have people living well into young adulthood who were born with HIV infection. And their needs have shifted in some interesting ways. One, they weren't expected to live. So they weren't necessarily prepared for the tasks of young adulthood, such as dating and relationships and careers and family formation. So they've arrived at adulthood somewhat unprepared. Their providers didn't think they were going to live, and their families didn't think they were going to live. They also have a highly stigmatized illness, and so that's not discussed frequently outside of the family, and therefore they are faced with having to negotiate intimate relationships with an illness that is not easily disclosed. So what they have are needs regarding education, career aspirations, and managing the tasks of young adulthood, establishing relationships and deciding on children and that sort of thing.
Yeah, what has the research revealed about this population and I guess how they've coped and changed?
Well, research has found that they are engaged in the same kinds of behaviors that young adults who don't have HIV are. So they're engaged in sexual behavior, they're establishing relationships, they're having children, and that they follow the same path that many of their uninfected peers do. My research sought to shine a light on not just the behaviors, but the process. So we know that in the state of North Carolina, if you have HIV, you are required to tell your partner that you have HIV before you engage in sexual intercourse. Well, the problem is that's all that's told to them. You got to tell, not how do you do that, when do you do that, how do you prepare for that conversation? And so I wanted a broader look at the whole person. A lot of the people in my research said, I get told not to give anybody HIV and not to get pregnant or not to get someone pregnant, but not, do you want to have a family? And if so, there are better ways to do that than others.
Well, speaking of, I guess, ways to do that and the care that comes with it, why is transitioning from pediatric care to adult care challenging?
Well, it's challenging for several reasons. One is many of these children were cared for by the same pediatric team since they were born. So this is, in essence, another family, and it's the only place for most of them that they've been able to talk about their illness. So you have the same pediatrician and the same nurse and the same social worker caring for you through your whole entire life, and you hit 18, 20, 21, and now you're supposed to go to the grown-up doctor. Even for your average college student, that is often a challenging task. They're scary in the adult world. So part of it is the relationship. Part of it is also that because these kids were chronically ill, they may have been sheltered from some of the normal independent life skills that you might get. So making your own appointments, keeping up with your medication, that sort of thing. So when they hit adult clinic, they treat you like you're an adult and they say, come back in 3 months. There's not a follow-up phone call. There's not, do you need help with transportation? They're entering into a system that has a lot more patients per provider and don't have the same kind of support that they get in the pediatric clinic. And the other piece that makes it challenging with this specific population is that sometimes the folks in the adult clinic look different from them. So these are kids who were born with HIV. They did not acquire it through drug use or sexual behavior. And they're entering a clinic where most of the people in that clinic have been engaged in sexual behavior or IV drug use, and that's how they got infected. And so they look different. They might look different. And it's a different culture about how do you care for people. The pediatric providers get kind of chastised by the adult providers for coddling their patients and not giving them the opportunity to really be independent. And the pediatric providers tell the adult people, you guys aren't sensitive to the developmental needs of this emerging adult population.
Do you see that kind of conflict, the same challenges or issues with other diseases that are acquired in childhood?
Yes, absolutely. So I'm part of a national healthcare transition consortium, and the same narrative is shared, whether it's diabetes, epilepsy, the whole 9 yards. But what makes HIV special is that it is sexually transmissible. And that piece sort of sets it apart. It's more stigmatized than most of the other chronic illnesses that young adults might face, but those young adults face the exact same challenges. The adult place looks a little scarier. They're a little different over there. They expect you to be, independent, and are just sometimes at a loss for how to navigate a far more complex system regarding insurance and work and transportation, where they might have had those services as someone under the age of 18. They don't necessarily have those available once they hit 18.
Let's talk, transmission here for a second. There's been a rise in behaviorally acquired infections due to drug use or unprotected sex among adolescents and young adults in the U.S. as well. So as part of your research, you evaluated kind of the unique interventions designed to support adolescents living with HIV. What'd you find?
Well, one of the programs that we evaluated or assessed was a really wonderful program in Wilmington that offers a creative writing program to HIV-infected adolescents and also affected. So some of them had brought their friends or their partners. And the students would gather with faculty and graduate students from the creative writing program at Wilmington, UNCW, and they would engage in creative writing tasks, creative arts projects, and really had the opportunity to come together and have the chance to simply express themselves in ways other than just talking. So there was poetry, they have a website up, it's fabulous, they have artwork, and they actually, the first year they held a poetry slam, and the children, adolescents, got to share their stories, and their family members came to this event, and they were blown away. They had no idea how much was inside of these kids, because it's really not talked about very much within the family system. So that's one unique intervention that is low cost, that is useful to all kinds of people, but really particularly for those who have this stigmatizing illness.
In terms of this age group, why are we seeing an increase in HIV cases?
Well, several reasons. First of all, one of the biggest predictors of transmissibility is the viral load in the body. So if someone has a high amount of virus circulating, they're more likely to transmit the virus. And one can't take preventive precautions unless one knows that one is infected. So part of it is getting access to being tested, right? You have to be able to you have to know you're HIV positive before you can do anything about it. And once you know that, you can engage in safer sex behaviors. You can also get on treatment. And one of the things that's really amazing about the new regimens is that they can reduce the viral load, so it's undetectable. And that person is very unlikely to transmit virus, whether or not they're having safe sex. So part of it is access to testing, part of it's access to treatment, part of it is smaller populations that are sort of on the fringes of society, so to speak. So young men who are having sex with men within minority communities have not typically been embraced by those communities. And so they're either further outside of the access of care that other people might have access to.
We spoke earlier about adolescents and young adults with HIV reaching adulthood, and of course, the topic of having kids will come up. What has your research shown about their desire to have kids, the intentions of the group, what they're up against, and what their needs are in these situations?
I love that question. So what we found is that they have very high fertility intentions and desires, higher than, in my study, higher than any other reported study that we could find among traditional adults with HIV infection. So we found in my sample of 35, 88% plan, intend to or desire to have children, and of that group, 93 intend to. So this is a group of young people who really do want to have children. They want to have children. The problem is many of them have a misunderstanding about the risk of mother-to-child transmission. What we know is that if a woman is on antiretroviral treatment and her viral load is undetectable, she has a 1% chance of having an HIV-infected baby. That's amazing. It used to be 28 to 30%, at least in North America. So that is a dramatic reduction. That means they have a really, really, really good chance of having a healthy baby. But there's a lot of misinformation about that among this population. So they have a higher desire and they have low knowledge. And what I would like to see is for providers and family members to talk intentionally. I think the idea is if we talk about the fact that there's not a high risk of transmission, then there's going to be all these people having children. And it's kind of like, well, let's not tell anybody about sex and maybe they won't have it. That is not actually how it works, what we know from other people, other studies. So they really want to have children. Much of that is tied up into the losses that they have experienced themselves. Many of the people in my study, half of whom had a mother that was alive, half of whom had a father who was alive. So these kids have experienced a lot of loss, and that influences the desire to have children. I want to make up for what I didn't have. I want to make amends for what happened to me. I want to be a better parent than I was parented. And so it's pretty powerful, the motivations behind this desire. What I'd like to see is an intentional conversations around this and saying, yes, this can happen, but let's do it with you healthy. Let's do it with a partner who's going to be supportive of you. Let's do it with a partner who knows your HIV status and can be part of supporting you through this.
Given what we do know about HIV and what we're still learning, of course, we understand the importance of this research that you're doing. So how's it being used?
Well, it's being used in a couple of different ways. One way that I'm very excited about is I had the opportunity to be part of a think tank at the National Institutes of Health with a good friend of mine who I used to work with at NIH. And we gathered researchers and clinicians from across the country, well, actually not across the country, across the Eastern Seaboard, and we were able to think about what are the next steps for the field? What are the next questions that need to be thought through? And as a result, we brainstormed some future ideas of where we need to be going to support this population, because this population is going to continue to age. And as they continue to age, they're going to have potentially more health effects of being on HIV meds for 30 years, of having opportunistic infections, of getting ill if their meds start to fail. So we need to know how to best support them. So I think that this research that I've been doing kind of pushed the agenda forward a little bit and said we need to stop thinking about how to prevent them from having children and how to make sure they don't give HIV to other people, and really have a holistic view of them as young adults who can contribute to society, who want to be parents, who can be good parents, but they need the support.
How are you seeing that already have an effect?
Well, I'm seeing it happen in the ways that my discipline, social work, is thinking about issues of transition, is thinking about issues of family formation. So I know for my colleagues that I work with at Duke, they're very much focused on preparing adolescents to get ready for the next big steps in life. I think that I'm collaborating with some researchers out at University of Southern California, and when I approached them about this project, they said, oh, that's a great idea. I hadn't thought of that. So I think it's beginning to happen in little fits and starts, just from having conversations with people and say, let's think about the whole person here, about this person who has hopes and dreams and has been carrying around a burden. And let's see what we can do about supporting them as they move forward.
Have you been able to involve students in the research? And
Oh,
what roles have they had?
I love my students. I've had wonderful opportunities to work with students, both students who have brought to the table brand new questions and perspectives. And for example, I have one student who said, well, I want to know, what are the providers saying to these young people about their family interests and that kind of thing? Because if they're not going to get it from their parents, they need to be getting information from somewhere. And are the pediatricians talking to their adolescent patients about sexuality, and not just sexuality, but relationship formation? So she interviewed pediatric providers. She sent out a survey to adult providers, adolescent providers, pediatric providers, and we have this other piece of the puzzle. So we know what young people are telling us they're hearing, and now we know what providers are telling us they're saying, and they don't necessarily match. So that's been very exciting. I've had students that have been able to go to South Africa and interview nurses and midwives about their understanding of HIV, their perspectives on what the government is doing for women with HIV. I've had students who just are interested and say, well, what are you doing that I can maybe join in on? And so I'll hand them a bunch of transcripts and say, well, read through these and tell me what kinds of questions you see. And then we come back together and we talk through some of the questions. And one of the questions, I have a student that just finished up working on, she was looking at, so we have this group of adolescents that were infected from birth, perinatally. And we have this other group of adolescents who were infected, through behavioral means. Are they getting different sorts of information? So is the pediatric infectious disease provider saying, well, I'm going to talk to this group that way and this group this way? And is that a problem? We don't know yet. We don't know if it is. But we are noticing that there were some assumptions about the differences in these two populations that may not be accurate, but could be influencing clinical care. So I just love my students.
It's good to hear. Throughout your career, from your time at the National Institutes of Health to now, you've really focused your scholarship on changes in the HIV epidemic. Can you give us a forecast of what's next?
Yes, I'm so excited. So just recently, literally 3 months ago, I had a student who said, I'm really interested in HIV and adoption. And I said, okay, so that's really cool, because what we know is that there is a movement afoot, at least within the United States, to adopt children from other countries who have HIV intentionally and bring them back to the United States to be cared for and be part of a family. In the past, HIV and adoption was more linked to a family adopting a child in the early 90s and then subsequently finding out they were HIV positive, or a child being adopted as a result of family death. And this is very different. Well, we don't know much about these families' needs. We don't know much about the children that are coming over here. We don't know how many there are. So that's sort of my new little area that I've been getting to look at that I'm really excited about. And the other area that I'm beginning to really focus on are the guardians and the parents of these adolescents and young adults that I interviewed. What are their perspectives on their children having children? Some of whom have lost loved ones. Maybe there's an aunt who's caring for her sister's child, and now that child is 18, 22 and thinking about having children. What are their perspectives? And that's not a population that many people have focused on outside of the initial burst of pediatric HIV in the late 80s and early 90s, when they were trying to figure out how do we care for these kids. But now these kids are living much longer, and people haven't focused on their caregivers.